Next, we're very fortunate to have Representative Butler and Representative Hunt, both from House Commerce. Representative Butler is the current chair, but both are leaders and have debated a lot of policy over the years that would benefit consumers, protect consumers, balanced against the potential of increased premiums. So over the next several minutes, we'll get to hear about their experiences and moderated by our own Tyler Brannen. So welcome.
Thank you.
So that was a good presentation that segues well in terms of discussion that we're hoping to have. And I selected a number of questions that I thought Representative Butler and Representative Hunt might have a different opinion about. But that being said, you know, Representative Hunt made the comment to me before we started. The problem is I've been doing this so long, I've seen how things have changed. And when I reached out to Professor Frank to ask him to do the presentation, one of the things I did want him to talk about was look at how far we've come and look at some of the changes that have taken place. Because even when I started working in the 90s, it was you saw relatively weak benefits when it came to coverage for mental health. I think it's worth recognizing that state legislators have mixed feelings about federal laws, and of course the Parity Act is now more than 10 years old. So the first question I thought I'd throw out there is just whether or not that act, that federal law, is still necessary, considering how much attention we now have on mental health at the state level, and how many pieces of legislation come forward at the state level that may be more appropriate to address specific concerns in New Hampshire. So I'm not sure which of you want to start first.
Mr. Chairman.
Thank you, Mr. Chairman. In one of my previous lives, I was a psychiatric nurse. So I have worked in this field for several years and have lots of thoughts about care for this population and for these issues. And I never think that it is a bad thing to have an overarching requirement for providing equal service and equal coverage in any circumstance. It doesn't mean that we can't continue to look at issues on an individual basis. But I think the parity requirement is a basic.
So I have no medical background, have no insurance background, and I found myself on the Commerce Committee because I was a businessman, and I thought that this was a committee that best meets what my abilities were. I first got on the committee in 1989, and have served down into it most of it. One term I was off, but so way back in the early 90s, it was utilization review. And we had to battle over the concept of how many visits does it take before the therapist can figure out what they're going to do to help you. And then that would be utilization review, and didn't matter if it was 20, there was no numeric number, but that every time you got to wherever you were supposed to be, you had to go back and get reapproved. So meanwhile, other than that, all the mandates we had at the time was broadening who the providers were. And so when I first got on, it was social workers had already been approved, but it was pastoral counselors, and then we had family mental health providers, and then we have LADAC is I think the last group that got in. And the issue was always is that they would go to a different committee, in the ED&A committee, and get licensure, and then they would come up to our committee and say, okay, now that we're licensed, we want third-party reimbursement. And always for my side of the aisle, the Republican side of the aisle, it was all we're doing is adding the increase of health costs. All we're doing is, and the issue for mandates in general, and there's lots of mandates, but in terms of all mandates, if we were going to lump them together, was the perception that you were adding more health costs to a system that's already costing too much. The other problem we had was, and I have to admit I'm part of this party, and that is I never really understood the concept of parity, because in my mind there wasn't. I mean, you gotta say, well, an insulin patient, once we realize that they have diabetes, well, we're going to try to figure out what's the right combination and, how we're going to treat it. And then we have this marvelous pump that can pump it. And so we're going to get to solve. Everything was where we can get to resolution. The idea of that talk therapy for the rest of your life is a resolution. It doesn't fit. Really, at least for us, maybe somebody can explain to me how it worked. But for those of us who argue that parity was never going to happen because there was no way we could compare that. Let alone the fact that it's absolutely true, as Dr. Ray was talking about, is how our health insurance system is built around how to limit care. In other words, the whole managed care concept was that we would have a gatekeeper, and the gatekeeper is going to tell you which provider you can go to, third party, which other specialist you can go to, but that you're always going back to that gatekeeper, your primary care physician, to decide what's the next thing for you to do. And to ask that primary care physician now to also be an expert on mental health issues and also know what are your mental health needs and help, make you advise of that, I don't see how that's possible. So unless we're going to mandate that we're going to have a different kind of mental health primary care physician, I don't think we're ever going to get to parity, because you can never. You have to have somebody who's managing it and who's saying, okay, all right, so you tried that medicine, it didn't work. Now we need to do something different. Now what? So here now we'll refer you to a different specialist. There's nobody in the mental health system that's going to provide that kind of streaming, and then when you get down to it. Certainly for people on my side of the aisle, the idea that talk therapy is going to be the solution for the rest of someone's life they can't imagine why we'd want to pay for that. And obviously in some cases, I guess disclosure, I have a brother who's a psychologist, and he actually used to get payments. He's in Cambridge now. He used to get payments, but now he's just gone straight private practice. Because it was just too much work, and he had enough patients who were willing to pay out of pocket. So I don't know about your disparity issue that you were talking about. I don't think they're ever going to. I think it's actually opposite. That physicians, if they're psychologists or psychiatrists, they're probably more attractive to become private practice. They probably get paid more than if they stay in the public in the healthcare system and get reimbursed.
And so now you see why we need a Parity Act.
Thank you. So Representative Hunt already started to answer the next question I was going to ask, but I wanted to ask more specifically about health insurance mandates in general. The way we define sort of an insurance mandate in the traditional way is it changes the scope of services that are covered. Sometimes gets a little bit confused with diagnoses and maybe even types of providers, but generally when you buy insurance, you should be covered regardless of your kind of diagnosis, without talking about pre-existing conditions specifically. So when we talk about the incremental cost of coverage, it relates to specific services. So I guess the first question is do you have a general position on mandates? But more specifically, is there anything more refined when it comes to mandates that have to deal with mental health services?
Okay, I'll start for that one. So very early in my career, back in the early 90s, we had, Matthew Thornton, Dartmouth Hitchcock was doing this it was about solid breast cancers, and that they had this procedure that they wanted to do, the stem cell, and they wanted to experiment. And they came to us, the legislature, to mandate this procedure. Now, I mean, obviously, breast cancer is a huge problem, and so it became almost an emotional issue. And you're asking legislators who know nothing about medicine to have to make this decision. Now, we ended up passing the legislation, and then it turns out it really didn't be effective, and we ended up repealing it. But this is the kind of problem we get into, is that we're not physicians. We don't have this background. We don't know what we're talking about. And I would say, in general, with all the mandates that I've certainly gone through, and I feel like I've been around for 80% of them, if not more, was okay. How do we compromise? How do we set limits to them? So when we do a mandate, we're going to say, well, we're going to limit it to this. Interesting, we were talking about the autism mandate. Well, it's only for kids. whatever different kinds of mandates, we're going to put some kind of limit, some kind of governors on it, so that we can somehow control the cost of it.
And I don't have a particular position on mandates. Each mandate that comes to us has its own set of circumstances. And even though most of us have not worked in the healthcare profession, we hear from doctors, nurses, social workers, clinicians. We are an amazingly diverse group of relatively smart people who analyze these issues. And the process that we go through in the legislature is really a wonderful one, which pulls apart the questions that come before us and tries to put them back together in some reasonable way. And there is a multi-step process. I'm not uncomfortable with making decisions on mandates, and as it comes to the most recent ones on pediatric neurological conditions called PANS and PANDAS, and on infertility treatment coverage. I think we did a very good job on those. And so I'm glad that that process exists. I'm glad that there is a way for us to look at things that are not necessarily covered in specific, so that we can potentially offer support and services to people who need them.
Well, I was going to ask, do you feel the legislature is able to sort through coverage issues as they relate to diagnosis, treatment, standard of care, and the standard of care that providers are expected to meet? Sounds like you've both sort of mostly answered that, but I guess in terms of the timelines that are associated with hearings and sometimes the politics and how much attention you can pay to any particular bill and any particular condition that might be sort of a real concern of a particular group of patients. Do you want to say anything more about that? And can you speak to, I guess, the legislative process and maybe even options that exist when you feel as though you don't have enough time to focus on an issue? Or do you feel, and maybe Representative Hunt, you want to kind of say it's just too difficult for legislators to work through? So maybe we'll start with Representative Hunt.
Well, has there ever been a mandate you were opposed to?
Sure.
I don't remember.
Bariatric surgery.
You were opposed to bariatric?
Absolutely.
Well, that brings up a good question. There was another 2-year term in which I was also in the minority, and we passed 6 different mandates. And then after that, the next election, Republicans were swept in. We had super majorities in the House and the Senate, and so I put in a bill to repeal all 6 of those mandates, including the bariatric and the autism, and you would be amazed not a single one of those things passed. And the reason being was that everybody loves mandates. I mean, even a Republican who says I don't want to pay for it, but I want that benefit. Everybody wants the benefit. So the issue then gets down to, for me, as being the chair or ranking Republican of the committee, is the struggle is that everybody wink and wink. We want to hold down health costs, but we really don't want you to use mandates as the way to do it. That we want you to figure out some other way, like let's buy health insurance across state lines, which I don't think makes any sense. But there is always this pressure, and to figure out some ways to how we can narrow it down and control it. And I've always amazed, for instance, that Medicare does not cover for hearing aids. Okay, well, because everybody over 65 evidently needs hearing aids, and they decide that no, we're not going to cover it. So when it comes to the state, we had a bill in that we were going to try to cover it, and we ended up not doing it because Medicare wouldn't do it. So sometimes we have to.
I think we did do it, but we limited it to only a certain amount.
I think we did that for children. We limited it to
Nope.
$3,000.
Everybody.
Commercial market, and then there was MedSup. We
The
ran into a bit of an issue.
Medicare, right?
Yeah.
Yeah.
So.
The politics are interesting, but I find that you can have fruitful discussions even with very disparate perspectives and points of view. And we have 2-year cycles, and Sometimes it takes 2 years to look at an issue, and sometimes it takes 4 years to look at an issue. And I find in general that we do not pursue something that we do not understand in enough detail to make a reasonable decision. So we had 17 bills that we retained from the first year to work on further in this past session. And so I do think that there is time when it's needed, and I think we're generally smart enough to say we don't know enough, and this bill is not ready for prime time, and it will come back to us in a different iteration when it has more support.
Great, thank you. Is there anything you would say, I guess, to advocates or people who want to influence policy about what's most helpful going through the legislative process and perhaps what's not? I mean, whether it be through a study committee, a commission, or just through the hearings or individual contact with you, whether it be standing outside with signs. Are there things that you think are most helpful and things that perhaps are not?
All of the above. One of the things that I find interesting is that the department has held a working group on parity issues over the past year, 2 years maybe, and that it has brought together a broad spectrum of people in the industry, both carriers and practitioners and policy people, to talk about the issues of parity and to talk about the challenges that they have. And so I think those kinds of work groups, study committees, and working over a period of time through advocacy groups and community groups to flesh out the details of the concern and then bring it forward. This is my 6th term, and I have found that issues come back again and again if they need to. So we have time to define it and flesh it out in a variety of different ways.
Well, I think, ironically, this heroin fentanyl crisis that's happening is actually helped the mental health greatly in terms of putting more resources and concentrating on it. And sometimes it does take a crisis that get people to think how we're going to fix it. Like I say, I think we have to, for mental health, I think we need to totally step back and it's not just put some words on a paper and think that's going to solve the problem by calling it parity. We need to reinvent the process, and I enjoyed hearing what Dr. Frank had to say, because we really need to rethink the whole way we provide mental health services and how we're going to do that in a way that really helps people in the long run, rather than trying to think that we're somehow going to compare it to medical insurance. I think that sometimes you really need to really change the whole way we look at it. In terms of our parities, well, I'm on record saying stay tuned, that in passing infertility coverage is going to raise everybody's premium 5%. So we'll wait to see if I'm right or wrong on that one.
Thank you. So sometimes we see legislation, insurance legislation, that is intended to reduce barriers to access and sometimes payment for healthcare services from certain providers, perhaps. Some of those barriers might include high cost sharing, and certainly the Parity Act was intended to deal with that. But as we heard, just relative to your medical benefits. Other areas might be the availability of in-network providers, or even providers of a certain specialty, including non-traditional providers. Some of the other barriers might be related to a kind of a rigorous prior authorization mechanism. So do you feel that it's likely that more insurance-related legislation would be helpful to improve access to mental health care services? Or is there sort of a point where there's kind of diminishing returns and maybe some of the consequences that would be preferred to be avoided?
We need a revolution. We need to rethink the whole thing and not think that we're just saying parity is going to solve it. It's got to be we got to rethink the whole way we do mental health, because it's not. Frankly, I don't think it has anything to do with our medical system, and it's totally different. And we have to figure out how we're going to change that.
One of the things that I was thinking about during Dr. Frank's presentation is what kind of psychosocial practitioners are included in networks. If we are talking about the fact that you need a complex group of supports in order to deal with some of the issues relative to mental health, are psychosocial practitioners always included in networks? Is it a mandate that it's a part of a network? That would be something I think that would be worth exploring further. I think it is always an issue relative to cost versus benefit. There are times when the cost is worth the benefit. The dozens of mandates that we have approved over the number of years is part of the reason for that. So dealing with the cost relative to those barriers is always a piece of it. Prior authorizations, I think we've dealt with over the past few years, trying to diminish the impact, the negative impact of prior authorization, and yet to make it useful when it can be. It's all a piece of the puzzle.
Thank you. So the ACA, and of course the parity laws, dealt a lot with sort of minimum coverage in some ways and national differences among insurance markets. And I started out by talking about insurance mandates and as they relate to sort of the scope of services covered. So the question is whether or not you think there's been a shift from just expanding coverage to more refined areas such as network development specifics like network adequacy laws, or even going into areas where we're looking at reimbursement rates to providers. And there have been sort of parity among reimbursement bills that have sometimes come forward. So the question is, how involved should state legislators and, of course, insurance departments be with provider contracting and payment? And is there anything unique as it relates to mental health care services? In other words, would your opinion differ for mental health services, but you might feel otherwise for other types of services?
We had a bill in that, I always get this wrong, but the ophthalmologist and optometrist, and that one does what the other one does, and they want to get reimbursed at the same rate. Okay, it's the one who was the doctor. And I go, when we ended up, I think the bill barely died. And there's the issue is, do we really get in there and legislate that, what premium, what are we paying physicians and when they're doing it? Obviously, the bottom line here, and I think it's just so well, when we sit there as legislators, every bill has a grain of truth to it. Every bill has, it's when you put those words in and the details of the words and how they're implicated and how they're used. I don't know, we had another bill, I forget what it was, but it turns out one of our insurance companies found a loophole in the way it was written, so we had to revisit it again. So it is almost better, is that, to me, the word parity is the problem. I think that you got to back off. If you're going to say, if we really truly mean parity, we really truly don't expect the networks to provide it. It's a totally different network. It's a totally different product. It needs to have their own primary care physician. We need to pull it all out and treat it separately. And that way you can really measure what it's doing and who is providing it to and who are the right providers and the right network, rather than trying to merge them into the two systems. And because there's no way you can ever ask your primary care physician to be giving you to be directing your mental health care.
I am chairing a commission and a study on prescription drug costs. What is said repeatedly during those meetings is how complex the challenge is, how complex the problem is. And relative to the cost of health care and the provision of health care, there can be no more complex a beast than that. Looking at the pieces, I think, is valuable. The talk of having effective networks, especially I live in the North Country, so how do you define a network that provides a broad range of services? And when you are talking about mental health services, it becomes even more of a challenge. I don't know if you're going to ask about telemedicine for a future question, but you know, in the North Country and in general, telemedicine can be a very effective way of providing services. I think the legislature can be useful in looking at some of those pieces. I think that the carriers understand their challenges and the creation of their products a lot better than we do. And so it's when the advocates, it's when the consumers come to us with a problem that we can deal with it. I don't think that we are, I don't think that we should be defining what, how we move forward. We should be working with those problems and issues that come to us.
Thank you. So traditionally, health insurance has included services that are considered rehabilitative. So the patient needs treatment in order to get better. There's been some shift toward habilitative coverage, and the ACA does make reference to this. And to the extent you think about treatment for autism, that might potentially fall into that category. So the question is, do you feel health insurance coverage for habilitative treatment, particularly of mental health care services, is appropriate?
Well, we did pass autism for under 18. Yeah, we did. And that was to relieve pressure because the schools were the ones who had to provide the services, or were providing the services.
I think that habilitative services can be very useful, can be very effective, the goal for all of this that we're talking about is to provide effective treatment as early as possible to prevent more expensive treatment in the future. And so habilitative services fall under that rubric, I think. It is possible to help someone achieve effective activities of daily living through habilitative services rather than having to wait until they devolve further and have to have other kinds of services that are covered.
So it sounds like potentially both of you are saying that mandates for habilitative services might be appropriate. Did I understand that correctly?
I don't think I voted for it. So, you know, and it's you know, again, everybody wants a mandate. The mandate wouldn't be there if people didn't feel like their insurance company wasn't paying for it. You know, if we had back in the old days when we had indemnity plans where it was 80-20, everything got paid and we all had the 20, we just go back to the indemnity days and that would be fine. But we're not there. You know, we've decided we're taking this other new model, and this other new model does require that every time the insurance company says no, you call your legislator and say put a bill in. And those of us who are really, you know, trying to hold down health costs, all we can do is try to narrow it, try to you know, reduce the pain of the premium.
Let the record show that all of us are working to hold down the costs of health care.
Which segues well into my next question. It's possible to imagine that addressing some mental health needs could be considered outside of health insurance coverage. For example, through schools or state or local government initiatives, maybe even employers or other social welfare programs. So the question would be, do you feel there are mental health related issues covered by health insurance, or sometimes maybe there's the assumption they could be covered by health insurance, that would be better addressed elsewhere?
I don't feel qualified to answer that question. I don't know what services are being provided or could be provided in other environments that are currently being covered. I'm sorry, but I can't do that one.
Well, we've gotten involved in who is the provider. Like when it came to some benefits, like having the Bedford Ambulatory Center, that was a mandate that we, the legislature, allowed them to do a procedure that only hospitals could do. So that we have been involved in. And in the autism, clearly that was an issue for schools that they were having to absorb those costs. So we have dabbled in it, but it's pretty peripheral, and it's always in the guise that we are going to lower costs. That this other provider would be a lower cost provider, but I think that the fundamental concept of managed care is to limit the network. That's what it was invented for, and so as much as we don't like the fact that we're this is what we're operating on it, but this is what we have chosen because that was the only way we knew how to control costs.
Well, Representative Hunt, you gave the example of the autism mandate and sort of how perhaps some of that other treatment was being handled by the schools. I mean, there's certainly an interest in general about the social determinants of health and preventive care services and how far you extend. I mean, there have been benefits that have covered gym fees and some other things that may have some impact on people's healthcare costs or well-being. So I think, to the extent you can consider the question, there might be some other angles at it, but any other thoughts in terms of, and of course even Medicaid, if you look at some of what they cover, it's often related to transportation or other things that may be outside of our commercial health insurance products today, but clearly there could be interest in sort of bundling some of those under other services under health insurance.
I would not burden insurance with any more things than they've already are burdened with.
Still, I want to see it.
Yeah, understood. Well, I've gone through most of the main questions that I wanted to address that were piggybacking off of the presentation, but I also wanted to give you the chance to discuss anything else that we haven't, any points you'd like to make, perhaps responding to anything you heard in Professor Frank's presentation.
No, I think it was really very insightful. It was right what I've been saying all along. The danger is in the language parity. That it, and so often I see it in the legislature. People think words can solve problems. It's how we have to revisit the whole, rethink about what we're doing, and instead of calling it parity, we need to say this is what the proper way of mental health care needs to be provided to people, and that is that you cannot use the same model. It's different. It's a different model.
And we're all here because we are dealing with the system that we have, and the importance of the Parity Act and the Affordable Care Act, I think, cannot be underestimated for the provision of mental health care. It is critical that we provide a reasonable range of services that can be paid for through the systems that we have, and I think the Parity Act is, or the concept of parity and the effort to provide equal service through our insurance products is incredibly important. Yes, diabetes and an appendectomy and depression don't square up, and yet we need to work to find a way to make sure that those people who are suffering with mental health conditions are provided the best support possible, and I appreciate having this discussion.
Great. Thank you both for participating.
Yeah, thank you. Yeah.